Okay, hi everybody. I think we should probably get started. So to introduce to the stage, Laura McKinney, who's co-lead of AthenaDAO, and she's going to be talking about women's health research and overlooked opportunity in biotech. Thank you.
Thank you, Sarah. Thank you everyone for being here. I was saying that I was not quite prepared to give a presentation like this. I'm so used to Zoom. You're gonna have to bear with me if I fumble or make mistakes or say the words wrong. In any case, my name is Ramin Kine and I'm the core lead of AthenaDAO, the decentralized collective looking to fund women's health research. Let me start by saying that I am not a scientist. So I am the living proof that you can, I'm a great example of how with decentralized science, you can organize around causes that matter to you. I have experience launching and growing consumer business and have worked with luxury brands like Louis Vuitton and consumer tech companies like Apple and Amazon. It was in my advocacy work in longevity that I became obsessed with menopause, and here we are. I'm sure you have heard about the infamous Valley of Death. A log from Bio actually mentioned it in his first presentation today. For those in biomedical research and biotech, the Valley of Death is an important theme. A friend yesterday actually said that pretty much everything in biotech is in the Valley of Death. A nod to my friend. But I actually did go up and look up the definition. And the Valley of Death in R&D it's used to describe the period of the development of a product or service when a significant increase of investment is required, making the risk of failure much more likely to outweigh the potential future return. When it comes to women's health, we're nowhere near the Valley of Death. That's not a problem we have the pleasure of having. So rather than tell you about how criminally underfunded women's health research is, or or tell you more of the horrible stats, such as how in 2020, 10% of the NHS's research funding went to women-specific conditions, I am instead going to make a case for how ignoring half of the world's population is one of the silliest mistakes in innovation and business that we are making in modern times. When you think that 1% of healthcare research and innovation is allocated to female-specific conditions, you can imagine that we're leaving a lot on the table. For example, menopause and its associated symptoms are not capturing global disease burden databases, which looks broadly at causes of death, disease, injury, and health risk factors. We're leaving a lot on the table, from contraception to menopause, basically anything that affects the odds of you being here. Because if you're not a woman, you have a girlfriend, you have a sister, and you have a mother. And speaking of mothers, this meme is going viral right now on Instagram, and it says, "Motherhood is not every woman's calling." And I added to that meme, but menopause will happen to all of them. Again, when you think of the total addressable market, you're thinking of half of the world's population in this one condition in women's health, menopause. I did say that I'm obsessed with menopause, so you're gonna hear a lot about that. But women's problems do not sound sexy. Who really wants to talk about menopause? And if that's not your jam, if your thing is solving big world problems, you have to think that we're heading for an infertility crisis. Or how about something more incredible, like an open source artificial womb? And as everything starts with science and technology, there is a unique opportunity in change to work in women's health from the ground up, with decentralized communities, empowering researchers, and changing the current paradigm. Since no one is paying attention, there's a lot of opportunity. It's like it's like a blank page. From things like standardized women's health data sets, computational biology focused on women's health, academic publishing, and as I said, what about an open source artificial womb? At AthenaDAO, we're first focusing on the areas of research that are most underfunded, such as ovarian aging, menopause, polycystic ovarian syndrome, and biomarkers for all of these, as well as endometriosis and uterine fibroids. So when I mentioned that 10% of women's health research goes into women's health, of that, 1% goes into these conditions. But given that half of the population will go to menopause, if you actually kind of do a very basic math, things don't really square. As a progress to date, we were selected as the first cohort of BioXYC, which we were very honored about. We've already presented at an academic conference, and we just recently published a reproductive health report, which is actually our first public good. It was thanks to a Web3 tool, Gitcoin, that we were able to do this. We've onboarded about 10 to 15 active contributors in academia, venture, and research. And we have also run a series of talks with the leaders in the space. More importantly, and something that we're very proud of, is that we are already evaluating projects from institutions such as Harvard, Cambridge, and many more. We count with the support of many biotech and research institutions. And our goal is to become the leading global community-enabled platform driving translational and transformational women's health research, education, and funding. So with that said, we're actually going to have a panel on women's health research. And I have two amazing scientists with me today. I'm going to get them to come on stage. Hello? Can you guys hear me? Yeah. So to do the women's health research panel, we're going to start with the panelists introducing themselves, and then we're going to get going.
Well, I started in biology and science through my passion and interest for longevity research, which was at the time very underfunded and very obscure topic that you couldn't get funding for. But that just motivated me more, and that's why I did my bachelor's in molecular biology and later on my PhD in aging. And it so happened that my project was more geared towards reproductive aging. And it was astonishing to me how little we know about this area. Let's talk about it. The ovary is such a good mode of study aging with because everything happens so much earlier, but that's not really recognized in either field. And it was an astonishing area because there is so much more to be found out that can help so many people. And now I finished my PhD, I left academia, and I would like to help translate great research, both in longevity and reproductive aging, to the people who need it most. So I'm currently working with AthenaDAO and BioTech and more traditional VC, which focuses on longevity projects.
Hi, my name is Yulia Yurich, and I'm a molecular scientist, and I'm a postdoctoral researcher at Genus Glycoscience Lab in Croatia. And actually, we developed a blood test that can detect early signs of perimenopause, and we are looking to develop it further to also evaluate effects of HRT, so hormone replacement therapy in women. My current position is product development, and working on it very actively, as you can see. And I want to bring women health and wellness and longevity.
Thank you. So you already know who I am, hopefully. If not, my name is Sarah Kini, and I'm the core leader of AthenaDAO. You hear that there's not many use cases for Web3 from people who are not into Web3. And the reason I got into decentralized science because I thought it is really the best use case of actually tackling real world problems. Well, of course, that's what I would say because I'm into decentralized science. But I wanted to do kind of a live workshop to contextualize things. So I was around London and I went into a Boots and I found this on the clearance bin, a menopause test for £2.99. So basically I said, need to cancel the talk because our work is done here. I mean, $2.99 from $9.99, and a menopause test that's supposed to tell me if I'm going through menopause. I know that this is not real. But since I have scientists here, this is an opportunity for them to talk about why this is not real, why it's an opportunity we actually get evidence-based products, and why decentralized science can help tackle this, and also become, I mean, it's a massive opportunity because women are willing to take these tests because they're desperate when they're going through this in their lives. And we're selling them crappy products. What if we could actually give them things that do actually work? So Maria, I would start with you. Why is this not real?
I mean, I'm sure it's real, but what does it actually tell you? It's a one-off measurement of FSH, which is follicle-stimulating hormone, and it is the hormone that's secreted from your brain, from the pituitary, to basically signal the ovaries to grow follicles. So it could indicate that you're entering menopause if it's very high, but that's mostly because the ovaries start producing estrogen, and estrogen blocks the secretion of FSH. So if you don't have estrogen, there's nothing to block you to get high levels. But if that test actually tells you anything, it's very controversial. Because FSH levels vary constantly throughout your menstrual cycle. It's a fluctuation up and down all the time. And it goes up dramatically when you hit menopause. But that will be a very distinct point in time. So you can't do anything about it at this point. So we already know you have menopause and then kind of confirm it with that. But it does indicate, I think, a big problem that these products are so needed, and women in that kind of market around menopause, and around people who are trying to conceive, it's very exploited because they're desperate to find out, and we don't have anything that's good enough to give answers.
Just for context, I think recently the menopause market, and just what we have right now, not even actual real solutions, is valued at $600 billion worldwide. So that's what we have right now. But I think Julia can tell us more about why this doesn't work. It has to do with perimenopause.
Yes, of course. So menopause, as a word, means meno is menstrual cycle, and pause means stop. So it's when you're diagnosed with menopause, it means that a woman hasn't had her menstrual cycle for the past 12 consecutive months. So you're basically diagnosed with something which is already, which you already have been gone through for the past year. But what I wanted to say actually is that today this hormonal test measures your FSH levels, but your FSH levels really vary a lot, and they even vary within one day. So when a woman does this test of FSH during the day, the levels could be fine, but when she wakes up during the night, all sweaty, having hot flashes, then if she does the FSH, it could be very high. So they are not reliable because they vary a lot. And although they're not reliable, UK government spends £9 million each year for this testing. Why they do this? Because they don't have a reliable test. So how do you diagnose menopause today? You have to go to your doctors, you have to do hormonal tests, you have to accompany them with the symptoms the woman has. And often the symptoms are quite similar to other diseases. For example, women experience brain fog, or they're having trouble sleeping. They experience anxiety and often get prescribed with antidepressants. But basically, you're not fixing the core problem of women, and that is the hormone deficiency which they are going through before entering menopause. And this is the period which is called perimenopause. And perimenopause can last, it actually on average lasts for 7 years before one gets diagnosed with menopause. And now today we know that in UK it takes 6 doctor's appointments It takes 7 doctor's appointments and 6 years to be diagnosed with menopause. And during the period, women suffer with all those adverse conditions. And what's most important, and what we see in our research, is not only the symptoms, it's actually what's happening on the molecular level. And this is increasing inflammation. And inflammation is the root cause of chronic diseases.
Okay, so everybody got a lot of education here on what's going to happen to all women as they get older. If you can imagine going through that, that's not something to look forward to. Because I know the women that have had it did not enjoy it that much, so it varies really. But one of the biggest things of why I got so obsessed with menopause is because I learned that women's cellular aging accelerates during this period, so it really affects our health outcomes. When you think of it at the turn of the century or before that, women would potentially die 2-3 years after having menopause because our lives were much shorter. 50 to maybe 60 years if you were lucky. Now women are spending a third of their lives postmenopausal, and after menopause there's an increase of heart disease, Alzheimer's, at risk increase of those diseases, as well as osteoporosis and cardiovascular disease. So women's longevity is greatly affected by this change, this biological change. Now, we've changed a lot of things in science. There's no reason why we can't change this too. And this is where decentralized science can actually play a role, because this area is looked by investors, but with solutions that sometimes are about just management of the condition, or, oh, here's your patchouli oil to like feel much better, empowered, yay, love menopause. So when we're talking about when I said in the earlier talk that women's health is a massively overlooked opportunity, is because there are very interesting problems to tackle with a huge audience that would be ready to try anything. Also, keep in mind that 90% of healthcare decisions at home are made by women. With this said, as working in venture formation at Apollo Health and being between BetaDAO and Apollo Health and AthenaDAO now, what do you think, Maria, are one of the areas that we could work with decentralized science to tackle the issue of menopause?
I think the case for Athena, it would greatly benefit for having a community of women who have direct interests in the projects that we will be funding, the research that we will be supporting, and the outcomes of it. And not only would they have the information, but they could potentially have ownership in all of those projects, which is what we're all here about. So we are not only focusing on menopause, but a bunch of other very widespread conditions, from PCOS, endometriosis, ovarian aging, which affects fertility. And as our lifespans, as you mentioned, are growing, our reproductive lifespan is staying the same. And with our lives changing and our priorities shifting, a lot of women are faced with the harsh reality that too much time has passed, there's nothing they can do anymore. And they still feel so young, so energized. It's like 40, 45 years, say, like you can feel like you're in prime of your life, and actually your system is entirely gone. So I just think we need biomarkers more reliable than this, that are integrated in the healthcare system, ideally. And as Pops News, for example, they're given every year. You have to do it to track your progress. And what we also want to focus on is therapeutics. So we can do something about it.
Julia, you know a lot about biomarkers, so please tell us more about the importance of them and what you actually are developing with Black age and menopause.
Thank you for this question. So basically, what we were looking at is how to some kind of make or find a biomarker which would go beyond this hormone fluctuation And hopefully we've been in the life biology for the last 15 years. So looking at immunoglobulin G, the most prevalent antibody in the blood, and we figured out that the activity of this antibody changes as people are getting older, so it's becoming more pro-inflammatory. And we made it into a biological aging biomarker. And then we were tracking with men and women, and we saw that men age linearly, constantly, but women tend to be younger biologically, but until just right before the menopause. Before menopause and with entering the menopause, in a period of perimenopause, women tend to age 2.5 times faster. That means that their inflammation level, which we are measuring with our glycogen test, tracks the increase in chronic low-grade inflammation. And this was something very significant for us. We thought that this was a big discovery because inflammation, in our case, tracked by this biomarker, so IgG and glycans, like technology, can also track the decrease in production of estrogen, which women is going through. So basically, we are now developing a product which is called NanoAge. And by testing your biological aging and the pace of biological aging, we can sense when we can work as a predictive biomarker and can tell you if you're aging too fast and if you're entering perimenopause. In this way, we will make women be aware that something is going on, and they can manage the inflammation, and they can decrease the health deterioration and live more quality life in their years.
So I just want to contextualize why we have obviously a CSO of a femtech startup, because there was a process that, as I might have mentioned, and Maria did say when you were presenting herself, we're both AthenaDAO alumni. And as a matter of fact, MenoAge was a project that also went through the AthenaDAO pipeline in terms of being up for potential funding. It didn't work out, but with AthenaDAO, there's another opportunity, and looking from another context. And why this is interesting in decentralized science is because, for instance, BlackAge and MenoAge are not just doing the venture part of it, but they also have the research. And where we can play a role is in actually funding more research to get more data points so that the actual startup does better. One of the reasons there's not enough femtech startups or enough funding is because there's not enough science. So science is everything when it comes to actually making progress. And one of the interesting things about a DAO is that we're not necessarily a fund. We're also not an academic institution. We're a hybrid of those things. And we can do things that funds can't do. And we can do things that academic institutions can't do because they're tied to the certain rules by their prestige or the things that they have to do within the context of their countries. We have, for instance, contributors from Singapore, here in London, in the United States, and hopefully we're going to have more after this conference. But why I thought using the menopause test, which is such an unsexy conversation, I know all of you guys want to talk about computational data and algorithms and data assets and all of this, and I just want to tell you, all we want is a really good test that all of these women would actually use if it was truly available. With that said, I know that a lot of people usually have questions about why a DAO, what are we doing, how are we doing it, so I'm going to open the floor for questions. Any questions?
Hey, yeah, I just wanted to ask, and pardon my ignorance if I'm missing the point here, is the test to work towards eventually coming up with some kind of treatment to prolong the pre-menopause phase, or yeah?
Well, actually, we are looking also to treatment options, which will be if the menopause, you think of menopause as a hormone deficient state in women, then the logical would be to supplement women of which they are deficient of, and this is estrogen, estradiol, and progesterone. And today we have magnificent products which are body identical hormones, so 17-beta estradiol, and we have micronized progesterone. Studies which have been done have shown that its use is transdermal, and this use, if the dosage is, of course, it has to be personalized, it minimizes any harmful things that you might consider connecting with the hormones.
Brilliant, thanks.
Just pass it to her.
Hi, thanks. That was super interesting. I just wanted to ask you, when you said that you can do stuff that academic institutions can't do because of prestige and other, constraints, what are those things?
The main thing is being able to work with different research institutions. We're not tied to one, right? So if a researcher is in Singapore, they can do projects with us while they're out there at the research institution. If you're in Cambridge, you can still potentially maybe come and contribute to us and have another path to work on your projects. Yeah. So the bigger thing is not the being tied, but the fact that we can be more collaborative. Yeah. So we don't have one particular institution that we have to work with or we're tied to, and that's the big thing.
Yeah, and just another question, if you're a woman and you want to, contribute to this, or what can you do as a woman?
So every woman can contribute because, as I said, I'm not a scientist, but if you're a researcher and there's something that you're working on, not even tied to necessarily the conditions that we're looking at, you could potentially be one of your scientific evaluators, or we're also doing a lot in terms of publishing. We're going to publish a second reproductive health report. We're looking for more contributors to actually start working with us in different areas. If you are not a researcher and you are a communications person, you can come work in our communications and awareness groups. If you are a venture capitalist, you can come and evaluate the research projects that we're looking at to see which ones actually have the most potential. There's so much that can be done, it's just we have to do it. Right now we're focused on the science. We really are focused on onboarding the researchers, the scientists, the academic institutions. And when we actually do get proper funding and do more things, actually have the science very solid, our next step is actually the community. How do you actually reach women that are not researchers, scientists, the ones that are on Instagram finding information about their health? Because women's health information is not that readily available. How you curate, how do you actually provide a service and actually make women realize that women's health research is so underfunded, it's actually a massive problem. Women don't know this for context. So guys, don't feel bad if you didn't know. Women also don't know this. So there's a massive education gap that even decentralized science has to fulfill. For us, it's another layer in trying to get everyday women into our community as active participants. Maybe for some of them, it's eventually when we have tokens or memberships, they can just join and say, hey, I'm putting instead of $5,100 to like this thing that doesn't mean anything, my money is going towards scientific research or getting better solutions to women. But the first step is join our Discord. It's too bad I don't have our page there anymore, and I skipped that page altogether, but you can find us on Twitter, follow us, share our mission to your friends, family, women in your life, men in your life that are into reproductive health or women's health. Happy.
So, proving the point that men or many people don't know, can I ask just a point of information question, which is, and then I'll ask the question, which is, according to Jennifer Garrison's presentation on this topic, there are only 4 species, 3 besides us, that have menopause. Is that correct?
Like, and they're mostly whale, and they're all whales.
Yeah. So,
FYI.
so if that's the case, and a lot of the science is remaining to be done, and you were talking about the therapeutic space, how do we actually do the model organism testing? Like, how do we actually do some of the scientific understanding and testing in labs to see if the therapeutics work, or how things are working? How do we understand any of that machinery?
That's a great question. So we could still do research in mice that can be relevant, and there are a lot of things that we don't understand that we need to do more research on. For example, why do ovaries age so much faster than the rest of our body? What actually happens? Because when you look at the curve of follicles or oocytes in your ovary, they gradually decline until you hit around 35 years of age, and then there is a steep decline. So what happens there? Is it some kind of a switch? Is it just damage accumulation that creates a bad environment, so they start dying more and more? And that triggers kind of a cascade. And all of those questions, I think, are going to help us find out about potential therapeutics in space.
Can you do that in mice?
Yeah.
Yeah, you could do. So the why mice don't have menopause? They're not menstruating species in the first place. So menopause is the cessation of menstruation, but they do run out of eggs before their lifespan is complete. They also decline in reproductive function, so there are shared aspects of it.
I just want to say that if you read our reproductive health report, we tackle that subject there because there are researchers. Embarrassing how we hear. But we do, there are researchers that are actually working on models that induce the process of menopause in mice. I think what's the other rodent that have here is going on? Yeah, the naked mole rats. And then the other thing on the reverse that Dr. Jennifer Garrison says from the Global Consortium of Reproductive Longevity, who is the biggest consortium in the world right now tackling ovarian aging, is she points out how tackling longevity through ovarian aging makes sense because ovaries have a shortened span. So you could do longitudinal studies, you could actually do more. It makes sense that even longevity researchers start looking at ovarian aging as a really good model. I'm sure this is one of the reasons that why Maria was actually, she told me in her lab in Australia, doing little, what was it with little mice? The insemination. So she can tell you a lot about how you work with mice. Did that answer your question?
Great, okay. Any more questions at all for the panel? We do have a bit of time if anyone, oh yeah, one over here.
My question is, so we talked about treatment options, the hormone replacement therapy and so on. Would there be a cure? Like, what would you do? You know, and like kind of, you know, there is no, I just don't see a scenario where it's all gain. What do you lose? You know, so if you go with the hormone therapy, you know, what are kind of the things that you're giving up? Or let's say you cure menopause, there is no menopause. What is it that then you would kind of risk having? You know, maybe like increased risk of cancer or whatever it may be, right?
Well, first of all, menopause is not a disease.
We need to address that. It really, menopause is not a problem. Just when puberty exists, it's not a problem. It's something we exist to get through.
And yes, that's right. So menopause is not a disease. It's a physiological process when reproductive part of woman's life is ending. What the problem with menopause is, and especially perimenopause, is inflammation. So it is the part of the life where women experience increased, very high inflammation. Inflammation is actually connected to 3 out of 5 people die of inflammation worldwide. So it puts a woman in high risk of developing chronic diseases. Cardiovascular diseases get 5 times higher risk. Women have 5 times higher risk of developing cardiovascular diseases. They have metabolic diseases, osteoporosis, osteopenia. And what we figured out is that we want to be working in preventative manner. So each woman will go through perimenopause and endomenopause. What we want is that the harm to the health of a woman is minimal during the period, so that woman, when enters menopause and lives for 40% of her life, is healthier. So she has to be healthy, has to be active in society. This way, the person is feeling much better. She has a better health span, and we save money for the healthcare. So this is everybody's game, governments and the woman who is aware of this situation. Because now women are aware that inflammation is happening in the body. They see only symptoms and they think, okay, this will pass in 5 years, I can manage it, I can go through it. But what is happening is this health deterioration, and this is what we want to emphasize in women and make them actively act on preventing long-term health consequences.
I also wanted to say that we put a spotlight on menopause because it's just one area that has, half of the world's population going through it, right? But there are so many other things within women's health, like PCOS, endometriosis, metabolic health issues, so many things to tackle that could actually improve women's health condition. And these are areas that maybe we don't talk a lot about. There's a big taboo around women's health. So even doing this today here and just slapping menopause here to everybody to listen to it, it's a challenge because people don't want to talk about it. They don't think it's cool. And if I can appeal to the coolness, at least I'll appeal to the fact that I can tell you there's a huge amount of money to be made on actually helping women have better health. And women are very good consumers. I don't know why we are, but if you were giving us things that helped us, we would actually be happily spending the money because we already spend them on other things that don't matter. So I just say with this is an opportunity. It's not feel sorry for ourselves, I don't think so. It's that you're being very silly if you're not joining our cause. So please go ahead.
Yeah, I'm quite interested in this topic because I actually helped arrange HRT for my mum when she couldn't sleep when she was going through menopause. So yeah, I just wanted to know, is that kind of where the work ends? Like, is HRT an effective treatment for menopause, or are we still looking for better options for women?
So I don't think HRT is a treatment for menopause. It's a great tool to manage menopause, but it's not something that treats the underlying causes and can prevent it. But what we consider a moonshot would be something that tackles underlying causes, so running out of eggs. So we continue producing those hormones endogenously. So we want to find a way of how to preserve the eggs back in the ovary. But for this to happen, we need to have a bit of a forward thinking and start this treatment, if you want to call it that, at the time where we still have the eggs in order to preserve them. Otherwise, once you run out, there's nothing you can do.
Think of it, we live around 80 years now, and women live longer than men, but our reproductive system is in the cave times. So women are 25 years old, can't afford to have children, they want to have a career, and their most optimal time to have a baby is literally 25 years old. This is like a very biological conundrum we need to tackle. That's why they call it the global consortium. It has equality after at the end because it is an equality thing for women to also have the opportunity to, when they are financially stable, when they're happy with their careers, to maybe have children later than 40, which is not really a biological reality right now. And as I said, we have transplants. we have Viagra, we have things, I mean, we live 80 because we have vaccines. So we should have something for either extending our ovarian life, or putting it on pause, or delaying it. It's just, it should be there too. Any more questions?
Good throw. Can you hear me? Hello. You can, oh, sorry. Which I think is a little bit more technical. Recently, Apple, with the release of the new watch, made a big deal, or sort of not big deal, but they highlighted the privacy aspect of the reproductive data, which the device was collecting. Given that there is a political angle to reproductive health, I'm wondering what measures are you taking to sort of keep that in mind as you sort of engage with people, whether it's clinical trials or the eventual stuff that you build to actually help aid folks through.
So thanks for that question, because I know in decentralized science we talk a lot about patients uploading their data and those things, and when it comes to women's health, there is an added risk, but we're not right now currently working with the consumer. So we're not going to be getting data from users directly. We're working with research institutions, and that separates the data layer from us in terms of privacy, because the research institutions do have very strict rules as to how data is collected and how it's distributed and who they can share it with, and we would abide by those rules. Now, we also have the potential of working with startups, and we've had a discussion where maybe when one of the startups, they would actually say to the user, would you be willing to give your data for scientific research? But that's something that you put there as a preamble. However, if you do work in Web3 and the blockchain, it's tricky because data in the US, it's the right to forget, so the HIPAA compliance, you're not allowed to take people's data and then actually have it on a blockchain, which, as we know, code is for life. So these are technical issues that we have to tackle, but for the beginning, we're actually working with institutions, and they're handling the first part of the data for us, not like an Apple or app, which they are inputting. The information they're getting is what I would call the consumer, and we are not at that layer yet. Tell me in maybe a year and a half, and then I can tell you.
Okay, awesome. Thank you.
Thank you.
Thank you very much, everybody. Thank you, guys. That was absolutely fascinating panel and discussion.